of the skin cancer write-up with expanded explanations under each heading. Assignment, project, or lecture note. Haminifer 1. Introduction. Skin cancer is the most common type of cancer worldwide, with millions of new cases diagnosed annually. It originates in the cells of the epidermis, the outermost layer of skin. The disease occurs when abnormal skin cells grow uncontrollably due to mutations, often caused by ultraviolet UV radiation from sunlight or tanning beds. Unlike many cancers, skin cancer can often be seen early with the naked eye, which makes early detection and treatment highly successful. However, some aggressive types like melanoma can metastasize rapidly, leading to severe complications and even death. 2. Definition. Skin cancer is defined as the uncontrolled proliferation of abnormal skin cells due to mutations in DNA, typically triggered by UV radiation or carcinogenic factors. These abnormal cells invade local tissues and, in advanced stages, may spread metastasize to distant organs. 3. Etymology. The word cancer is derived from the Latin term cancer, meaning crab. Ancient physicians noted that malignant tumors often had finger-like projections resembling crab legs spreading into surrounding tissue. Skin cancer refers specifically to malignant tumors arising from different skin cells such as basal cells, squamous cells, and melanocytes. 4. Epidemiology. Skin cancer accounts for 1 in 3 cancers diagnosed worldwide. The highest incidence rates are reported in Australia, New Zealand, the United States, and parts of Europe due to fair-skinned populations and high UV exposure. Basal cell carcinoma (BCC) is the most common form, 80% of cases. Squamous cell carcinoma (SCC) accounts for about 16 to 20% of cases. Melanoma, though only 5% of cases, causes the majority of skin cancer deaths. Incidence increases with age, but melanoma is also common among young adults. Tab 5. Types 1. Basal cell carcinoma (BCC). Origin. Basal cells of epidermis. Characteristics. Pearly or waxy bump, slow growing, rarely metastasizes. Most common type. 2. Squamous cell carcinoma (SCC). Origin. Squamous cells of epidermis. Characteristics. Red, scaly, crusted lesion, may ulcerate, can metastasize if untreated. 3. Melanoma. Origin. Melanocytes, pigment-producing cells. Characteristics: irregularly shaped, multicolored mole, ABCDE rule, asymmetry, border, color, diameter, evolving. Most dangerous, high metastatic potential. 4. Rare types: Merkel cell carcinoma, aggressive neuroendocrine tumor of skin. Kaposi sarcoma, often linked to immunosuppression, e.g. HIV. Cutaneous lymphoma, cancer of lymphocytes affecting the skin. NAR 6. Causes: ultraviolet UV radiation, most important cause, damages DNA. Genetic mutations, tumor suppressor gene mutations, e.g. TP53. Chemical exposure, arsenic, tar, hydrocarbons. Chronic skin inflammation, non-healing ulcers, burns, scars. Radiation exposure, previous radiotherapy increases risk. Human papillomavirus, HPV, linked to some SCCs. For some risk factors: fair skin, blonde red hair, light-colored eyes. Excessive sun exposure or tanning bed use. History of frequent sunburns, especially in childhood. Family history of skin cancer. Immunosuppression, organ transplant recipients, HIV, age over 50 years, presence of many atypical moles, increased melanoma risk. Occupational exposure, farmers, sailors, outdoor workers. 8. Complications: local invasion and destruction of skin, cartilage, or bone. Metastasis to lymph nodes and distant organs, melanoma, SCC. Chronic pain, ulceration, bleeding, disfigurement leading to social stigma and body image issues, reduced quality of life due to repeated treatments and anxiety. Pathophysiology: 1. UV radiation damages DNA, producing thymine dimers. 2. DNA repair failure, mutations accumulate. 3. Mutations in oncogenes, RAF, RAS, and tumor suppressor genes, TP53, PTCH1, uncontrolled proliferation. 4. Evasion of immune system allows mutated cells to survive. 5. Angiogenesis, new blood vessel growth, supports tumor expansion. 6. Potential metastasis via lymphatic or hematogenous spread. Number 10. Signs and symptoms: basal cell carcinoma, pearly nodule, rolled border, central ulcer, rodent ulcer. Squamous cell carcinoma, scaly, red patch, ulcer with firm edges. Melanoma, pigmented lesion following ABCDE rule. General symptoms: non-healing wounds, bleeding or crusting spots, changes in existing moles, new lesions with pain or itching. 11. Medical diagnosis: History and physical exam, assess sun exposure, family history, dermatoscopy, magnified examination of suspicious lesions, skin biopsy, definitive diagnosis, punch, excisional, shave biopsy. Histopathology determines type and stage. Imaging, CT, MRI, PET, ultrasound for staging advanced melanoma. Sentinel lymph node biopsy detects spread in melanoma. 12 nursing diagnosis. Risk for impaired skin integrity related to tumor growth surgery. Risk for infection due to open wounds. Anxiety and fear related to cancer diagnosis. Disturbed body image related to surgical scars, disfigurement. Knowledge deficit about disease process and prevention. 13. Medical management, surgical excision mainstay, wide excision, Mohs micrographic surgery. Cryotherapy, liquid nitrogen freezing for small lesions. Radiation therapy for inoperable or recurrent lesions. Systemic therapy for advanced cases. Targeted therapy, e.g. BRAF inhibitors, vimurafenib, dabrafenib. Immunotherapy, PD-1 inhibitors, nivolumab, pembrolizumab. Chemotherapy, dacarbazine, temozolomide, less effective, rarely used. 14. Nursing management, prevention education, sun protection, regular self-exams, postoperative care, wound care, infection prevention, pain management, analgesics, relaxation techniques, psychological support, reduce anxiety, encourage positive body image, patient teaching, signs of recurrence, importance of follow-up, lifestyle modification, smoking cessation, healthy diet, stress management. 15. Treatment options, local treatments, excisional surgery, Mohs surgery, cryotherapy, laser therapy, topical therapy, 5-fluorouracil, imicamod, advanced metastatic treatment, immunotherapy, checkpoint inhibitors, targeted therapy, BRF and MEK inhibitors, radiation therapy, supportive treatment, pain control, nutrition support, counseling. 16. Psychosocial intervention, counseling and psychotherapy for anxiety, depression, and fear of recurrence, support groups to share experiences and coping strategies. Body image therapy for patients with facial or visible scars, family counseling to involve caregivers in care, education about lifestyle changes and long-term skincare. Number 17. Prevention. Avoid prolonged sun exposure, especially 10 a.m. to 4 p.m. Use broad-spectrum sunscreen, SPF 30, daily. Wear protective clothing, wide-brimmed hats, and UV-blocking sunglasses. Avoid tanning beds, artificial tanning devices. Perform monthly skin self-examinations using mirrors. Seek dermatological checkups annually, more often if high risk. 18. Conclusion. Skin cancer is the most common, yet one of the most preventable cancers. With rising awareness about risk factors, prevention strategies, and early detection, the global burden can be significantly reduced. Medical advancements in targeted therapy and immunotherapy have improved survival rates, especially for melanoma. Nurses and healthcare professionals play a vital role in prevention, early detection, holistic care, and patient education, ensuring not only longer survival, but also better quality of life. Thank you. Have a nice day.